Welcome to another of our webinars, today focusing on reaching marginalised groups. We've got some fantastic speakers today lined up, so a really exciting session ahead. We're going to kick off in a minute with Jenny and I giving some headlines and in terms of national update. Much of the information today is stuff that you should have already received, but just prompting so that you are aware of the information that's out there at the moment. And then we will be moving on to just checking. So we will then have a talk on gender inclusivity from Ash and Helen. Then moving on to perinatal mental health care within the armed forces from Ruth Guest. Health inequalities in the travellers and gypsy communities from Caroline Dan. And then we are launching the film of complex PTSD at the end. Now the overall film, we're going to show the full film today, is about, I think it's about 18 minutes in total. Now we appreciate that that may run over our allotted time because we're due to finish at 11:30. For those of you that want to stay and watch it, please do. It will be made available and the link will be sent out afterwards if you're not able to stay, but the opportunity to watch it if you can. All right, without further ado, we will move on to the national update, please. Okay, so I should have introduced myself properly at the beginning. For those of you who don't know and haven't been on these webinars before, I'm Liz Cullen, Head of Clinical Programme for Maternity and Perinatal Mental Health for Hampshire and Thames Valley Clinical Network, and currently during the COVID period working across the South East with colleagues in Kent, Surrey, Sussex, and obviously the regional maternity and perinatal mental health teams. So just in terms of national update, I just wanted to remind everybody, I'm sure you're more than aware, that obviously we're all working towards the maternal mental health services bids at the moment and the current timetable of events. So hopefully many of you joined us for the webinars that we've already held on both the 15th of July and the 12th of August even, in terms of going through both the bid template and the supporting documents. Those webinars are both available and were recorded, so if you weren't able to attend those and you want to catch up on them, the links will be available on the website and we will send them out again. So in terms of going forward at the moment, so today after this webinar we have got a workshop specifically for the BOB system in terms of preparing their maternal mental health services bid and the work for that. And again tomorrow there's a workshop specifically for the Frimley system. Next Wednesday there is a webinar on we're hosting it but being led by Public Health England on inequalities resources that will help to support you with your maternal mental health services bids, and that's in direct response to the presentation we had from Kate King-Hicks at the last webinar. Many of you requested some further support with that, so we've put that in and that will be held next Wednesday, and you should have all received an invite that I think went out around the 14th of August. If you haven't and you want to come, please let us know and we will send out further invites. Then just to highlight the date that's most important is obviously that the bid submission date is Wednesday the 23rd of September by 5 p.m. In order to get bids in, and then the panel is reviewing the bids on Thursday the 8th of October, and that's a regional process as previously mentioned. If there's any further support you feel that you require with your bids, then please get in touch with either myself, Jenny or Anita Finlay, and we will do our best to support you with that. Next slide, please. Okay, I just wanted to highlight today with regards to phase 3 of the mental health planning support tool. So as you're well aware, there are the deliverables for 2020-21, and what we want to highlight really is that this has been sent by the national team to the CCG commissioners for them to scope and scope both finance and activity targets for the coming period. The CCGs need to submit this on the 21st of September. So it's to make you aware that this is going on and encourage you to speak to whoever in your system you need to ensure that the correct information for perinatal mental health is detailed in there. But also, I guess, from a clinical network perspective, thinking about what support do you need from us in order to meet the access targets, being 7.1% by April 2021. So have a think about that, and if there's anything in addition to what we are already offering that we can put in place to assist you with hitting those access targets, then please let us know. Okay, next slide please. This was something that I just wanted to highlight. So this is a new fund that has become available, particularly for babies from deprived areas or BAME backgrounds, in terms of giving the best start in life. This is hot off the press, and my understanding is that applications, as we've said on the slide, you have until Friday the 30th of October to apply, but really just to highlight that there is this money and funding available. It is for third sector, so please, for those third sectors organisations that are on the call today, please be made aware, and for services, please let your third sector organisations and charities that you link with also know. So just to highlight really. Next slide please. Okay, now these next couple of slides are all information that you have already been sent out via information from us in the last couple of weeks, but just to highlight that there is the Ask Out for the Growing and Transforming the Peer Support Worker workforce, and the deadline for that is the end of this week in terms of expressions of interest for the Trailblazer site. You did receive these emails back again, I think it was the week of the 10th of August, so do go back through emails and check. They came from our generic inbox. Next slide please. And also included in that information was the masterclasses for the perinatal psychiatry senior trainees, and the deadline for that is the 30th of September. And that came in the same email, so again go back and have a look at that, and there's further information via those links. Okay, next slide please. This is something that went out to systems yesterday. It was sent out to from ourselves to the perinatal mental health specialist team leads and managers, and the request is for a return by next Wednesday evening. So nationally they are looking at digital and what's in place in terms of scoping what's available for mental health services in the South East. We do not, this has been sent down to us for completion and hence cascaded onto yourselves. We do not want to create a big industry in terms of getting information for this. It shouldn't be a big piece of work. It's really just about putting down what you already know and sending back to us. So just doing a quick sense check and completing and sending back. But you received this by email yesterday. Okay. Okay, so that's a bit of a whistle-stop tour from myself in order to give you the updates. As I said, much of the information has already gone out to you in the last couple of weeks. And now I'm going to hand over to Jenny, who's going to give the latest on the Embrace.
Hi everyone. For people that don't know me, I'm Jenny Walsh. I'm the clinical lead for Hampshire Thames Valley, and the same as Liz, working across South East to support at the moment. So since we last met, a number of quite significant reports for this area have been published, and the one that I wanted to particularly highlight was the Embrace Rapid Response Report. So as you'll all be aware, Embrace looks at maternal deaths, and they did a rapid response to look at deaths during lockdown to see if there were lessons to be learnt, and a number of lessons have come out of it. There's a number specifically for maternity about care of COVID positive women during pregnancy. But I think the one that I particularly want to highlight for today's audience is that we have now got a new red flag that's come out of this rapid response report for perinatal specialist services. And that says that if a woman is referred to a service by multiple referrers, so more than once, it can just be twice, but if a woman's referred in more than once, that should trigger an automatic assessment. Because obviously they've found in the report of instance where somebody, obviously there was concern about somebody and multiple referrals were made and not acted on. So they've highlighted that as a new red flag. And that's something that I wanted you to be aware of. And that I would recommend that everybody on this call reads it. It's not long and there's some really good information in there. If we think that we're likely to go into second wave or localised lockdowns through the winter, there's some really important safeguarding messages in there for everybody that's working in this area. Okay, next slide, please. We also had the Cumberledge report. So that was the 8th of July. So I would imagine that a lot of you have seen it or seen it in the press. The big message in this for the population that we serve is about valproate. Again, this isn't a new message, but it's highlighted the importance of it, and I would hope that all the specialist services on the call have protocols around valproate prescribing, and that all trusts have this highlighted for women of childbearing age. Oh, can you all make sure you've got your selves muted? Just had a little funny message then from somebody. Yeah, so that's really important, the Cumberledge report. Next, please. Next slide. And then this one, babies in lockdown. So this looked at the effect of lockdown on mothers and babies, and have made some quite high level policy calls. But again, I think that's a really important one for everybody on this call to be aware of that report. There's some good messages in there. And can I have the next one? Yeah, if you see the impact of lockdown on the families that we work with, it's really quite sad and challenging. Almost 7 in 10 found their ability to cope with their pregnancy or their baby had been impacted. Nearly 7 in 10 felt the changes brought about by COVID were affecting their unborn baby or young child. So I don't think this is new to us, and I think we might have anticipated it, but hearing it and reading it in black and white is very different, I think. And I think, again, if we can all be aware of the findings ahead of second waves and localised lockdowns, then we can use what we've already learnt to provide better services going forward. Okay, next one, please. So now I'm really delighted to hand over to Ash and Helen, who are going to present on gender inclusivity and are speaking to us today from the Brighton Trust. So over to you, Ash and Helen.
Hi everybody, my name is Ash Riddington. I'm a midwife at Brighton and Sussex University Hospitals NHS Trust, and my partner in this work is Helen Green. Unfortunately, they're not able to join me today, but I wanted to acknowledge that this is by absolutely a team effort, and it's something that we've been working on together for the past approximately 2.5 years now. So what I'm going to talk to you about today is the experiences of trans men and non-binary people during their pregnancy, and what we can do as a service to help to ensure that we are being inclusive for this population, and also why it's important to make sure that they're included. Next slide, please. So I thought I would start off with just establishing some of the basic terminology that you might hear me use, and it may be words that you're not familiar with, so we'll go right back to basics. Today, what we're focusing on is gender identity. You can see the second bullet point down. So this is a person's internal sense of being a man or being a woman or being neither. And this is distinctly different from somebody's sexuality, which is who they are attracted to. And it's also distinctly different from their sex assigned at birth, which is based on external genitalia present, rather than any internal sense of being. I'd also just like to note as well that it is different from gender expression. You can't always tell from the way that somebody chooses to dress or carry themselves what their gender identity is. So the only way to really know is to have a conversation with them. Okay. Next slide, please. Most of the people that are going to be seeking perinatal care are going to be what we call cisgender, or cis for short, women. This means they are people who were assigned female at birth, so they had a vagina and they were noted to be baby girls. As their life has gone on, they have also grown and developed and found that they identify as women. So we say that their gender identity, their feeling internally of being a woman, matches the sex that they were assigned at birth. And the term for this is cis or cisgender. Next slide. On the flip side, we have people who are trans or transgender. And this means that their gender identity, their internal sense of being, differs from the sex that they were assigned at birth. And we use the terms trans man and trans woman to refer to trans people. So a trans man was assigned female at birth, meaning that he was born with a vagina and a uterus, but at some point later on in his life he has recognised that actually his gender identity is male. We have trans women who were assigned male at birth, meaning they were born with a penis and testicles, but during their childhood or adulthood they've recognised that their gender identity is in fact female, so we call them trans women. Trans people may choose to transition socially, meaning that they will choose a new name for themselves, inform their friends and family of what their gender identity is, and ask to be treated in that appropriate gender role, which includes referring to them with the correct pronouns. They may also choose to transition medically, which usually involves taking hormones to help to develop the body in a way that feels more comfortable for them. And they may potentially seek surgical transition as well. Many trans people, but not all, will experience something called gender dysphoria, and we've got the definition from the Royal College of Psychiatry down at the bottom there. So it's the distress associated with the experience of one's personal gender identity being inconsistent with the phenotype, the body, or with the gender role typically associated with that phenotype. There's another group of people that may experience gender dysphoria, and those are people who identify as non-binary. And this means that their gender identity differs from their sex assigned at birth, but their gender identity isn't distinctly male or distinctly female. It's often used as an umbrella term, but it can also be a gender identity in its own right. People who identify as non-binary might prefer to use they, them pronouns instead of he or she. And they may socially transition, and they may medically transition as well. But it's a very unique journey for every single person, trans or non-binary. Next slide, please. People in the trans and non-binary community face significant health inequalities and challenges, and you can see some of the stats I've got here from a 2012 study. A significant number experience transphobia, unemployment, very high rates of unstable housing, with 19% being homeless at some point in their adult life. There's also high rates of mental health challenges and comorbidities, with 63% of people reporting suicides ideation pre-transition, and the amazing statistic that drops from 63 down to 3% post-transition. So that really shows us that transitioning, be it socially, medically, or both, is really, really vital to trans people's mental health. It's not a cosmetic process. It's not a social trend. This is really life-saving for this community. And finally, and very pertinent to us as healthcare providers, is that many trans people will have a previous negative experience of healthcare. That's 65% in this particular study. And that may be overt transphobia, or it may include lack of knowledge, awareness and training from their care provider. Sometimes people are refused care through their trans status, or they have pre-existing health conditions dismissed as being a result of either being transgender or side effect of hormonal medication. So it's really worth bearing in mind those historical experiences that someone may have had when you are caring for a trans or non-binary person in pregnancy. Next slide. Trans or non-binary people who are born with a uterus have all of the capabilities of carrying a pregnancy and birthing a baby, and that is a highly individual and unique decision for them to make. For some trans men or non-binary people, they really would not want to find themselves pregnant, and they will choose not to pursue that. However, for others, it is a perfectly viable and practical choice for them to conceive and to carry a baby. And during that process of pregnancy and early parenting, there may be some additional challenges for them to face. And some of them you can see listed here. We've got invisibility, the fact that in the media, in posters, in waiting rooms, in leaflets, you only ever see pregnant women, cis women, and the language that we use reflects that as well. So trans men and non-binary people may end up feeling invisible during pregnancy. There's also a lot of misinformation around trans pregnancy, and that extends to the medical community as well. Plenty of people aren't aware that following testosterone therapy, they can still be fertile, or that it is safe to carry a pregnancy as long as you're not taking testosterone at the time. Additional challenges that people may face might include the bodily changes involved in stopping testosterone in order to conceive, and then the bodily changes during pregnancy as well may increase the gender dysphoria which people are experiencing. While interacting with our services as well, they are very likely to face heavily gendered language. In the UK here, we're very used to talking about women instead of talking about patients, and obviously women is a gendered term. Automatically, we refer to people as she, we talk about breastfeeding, we talk about mothers. For someone who doesn't identify as a woman or as she, those terms can be really, really challenging to hear used about yourself. And that's a big barrier to seeking care that pregnant trans and non-binary people face. Caring for trans people is also not included in our curriculum as a standard. So many midwives and perinatal mental health practitioners have no experience whatsoever of supporting a trans person in pregnancy. And that can lead on to the onus being on the service user to provide that education, often in inappropriate times. The literature shows people being asked inappropriate questions about why they still have a beard whilst having an internal examination during labour, for example. That's not appropriate or fair to expect somebody to educate us as healthcare providers, especially during a vulnerable time in their lives. And finally, we have reports of people experiencing overt transphobia from healthcare workers during their pregnancy, being turned away from receiving perinatal care, or more more subtle forms of transphobia with deliberate misgendering, of persistently calling somebody she or woman or mum despite being corrected. As you can imagine, this whole range of additional challenges is a lot for trans people to face and has a few different outcomes. One being that many trans people or non-binary people don't actually seek any NHS care during their pregnancy at all, and they end up free birthing, not through informed choice, but by feeling that this is the only emotionally safe option for them. Obviously, that is not an acceptable outcome by any means. So we need to think about how to make our service more inclusive so that people feel able to engage with us. The other potential outcome as a result of these challenges is that people don't feel able to disclose their trans or non-binary status to us. And that's particularly relevant for people who haven't medically transitioned, so may not be visibly presenting their gender expression, or for people who are non-binary who, without having the conversation about their gender identity, you may not be able to tell from the outside how they identify. Next slide, please. So in brief, what changes can we make to our services to help to overcome some of these challenges and to make ourselves more safe and approachable as practitioners? So if you take nothing else away from this very brief talk today, I'd like you to remember that not all people who are pregnant or who are capable of being pregnant are women. A small proportion of those will be trans men, and a small proportion of those will be non-binary people. And therefore, if not everybody identifies as a woman, it's important that we don't just refer to women as a shortcut for childbearing people. And there's a few inclusive language changes that I suggest you start practicing and getting used to using in your everyday conversations. So rather than referring to women, maybe try referring to women and people, or childbearing women and people. Rather than women, you could also refer to birthing people. And also then thinking about the gendered language which we use surrounding the perinatal journey, such as breastfeeding. Some trans men will choose to feed their babies using their bodies, but will feel more comfortable using the term chest feeding. So we can talk about breastfeeding and chest feeding. It's also a great idea to ask everybody about their pronouns when you first meet them. So part of introducing yourself can be saying what your name is, what your title is, and what pronouns that you like to use. That makes it normal to share pronouns and makes it easier and safer for trans or non-binary people to bring that up in conversation, that actually they don't use she, her pronouns, they prefer he, him, or they, them pronouns. I also suggest you take a look around your work environment and have a look at the images that are on display. Are they inclusive of all the different protected characteristics? Do they just feature slim, white, middle-class women, or are they inclusive of a variety of ethnicities, sexualities, religions, abilities, and also gender expressions as well? Develop your knowledge. There is an increasing body of work out there that's available for free, with resources about the experiences of trans men and non-binary people during pregnancy and while interacting with perinatal services. And in a moment, I'll show you a link to a whole host of different resources. And finally, if you do find yourself supporting somebody who is trans or non-binary in their pregnancy journey, I really encourage you to be led by their own individual experience. They may be finding it very challenging. They may find their dysphoria has got a lot worse during this time. On the flip side, they might actually find that this is one of the first times in their life that they have been glad that they are transgender, that they are a man or a non-binary person who can conceive and can carry a baby. So it's really important that we don't impose our preconceived ideas of how somebody should be feeling during this period, but instead ask open questions about how they are finding this journey and be really led by them and their own individual challenges and joys as well. Next slide. Next slide, please. Here we go. So there's a few learning resources here which you can screenshot and go and have a read through later. But also Helen and I have created or are in the process of creating a bundle of resources for trans and non-binary care during the puerperium. And that consists of a clinical document primarily aimed at our midwives and obstetricians, and also a position statement and guide for using more inclusive language, which is one of the quickest and easiest changes to make. If you're interested in accessing these documents and our other resources, give us an email at bsuh.genderinclusionmidwives@nhs.net. We're currently in the ratification process for those documents, but we hope that in the next month or two they should be available for wider distribution. And we're very keen that these resources are shared as widely as possible so that we don't have individual trusts reinventing the wheel and doing this work from scratch for themselves. We would like to share the hard work that we've done as widely as possible and have as many trans and non-binary people benefit from this work as possible. Okay, thank you very much. And I'm now open to questions, if anybody's got them.
Thank you so much, Ash. That was such an informative talk and really thought-provoking, and certainly a lot that I learned, so I'm sure others will have done as well. I can see straight away there was a hand up, I think, from Charlie.
Hiya, sorry, just getting unmuted. I'm Charlie Marden, I'm the Programme Manager for SHIP LMS. So my question really is around sort of asking those initial questions. Some of our trusts, especially during COVID, have moved towards a self-referral booking process. And my first thought is it appropriate to include those questions there where we're asking questions around ethnicity and title, and really sort of the best way of phrasing those questions as well, whether it's just an open, is there anything you wish to tell us about your gender identity, or whether it's more specific?
Okay, great, really, really good question. And I absolutely agree that that first referral form is a great place to start opening up that conversation. At the very least, even if you don't have any trans or non-binary people using the self-referral form, it helps to raise awareness and to normalise trans and non-binary people getting pregnant. I think it's a great place to put that first question, and I think either would be acceptable. You could leave it as an open question: is there anything you'd like to tell us about your gender identity? Or alternatively, a drop down is what we use in our self-referral form just for pregnancy. We ask people what their gender identity is, and we give the options of male, female, non-binary and other, with other being a free text box to write extra information. That might be the easiest for you from an audit perspective, to be able to keep track of how many people you have coming through who identify as anything other than cis women. But I think an open box would be perfectly suitable. And then follow that question up when you first meet somebody face to face, or if you're doing video conference, and introduce yourself. Ask, do you prefer to be known by any other name? So if someone's got Natalie written, you could ask, do you prefer to be known by Nat or anything else for short? And what pronouns do you like to be referred to? And you might find that some people aren't sure what you mean by pronouns. So it's worth practicing just a brief sentence or two explanation of what pronouns are and why it is that you're asking.
Thank you so much. Really helpful, and thank you for your talk as well.
You're welcome.
Thank you. There's lots of excellent feedback in the chat box for your talk, Ash. Is there any other questions or comments that anybody would like to make? No. Okay. Well, thank you once again. That was a really, really informative talk. Really pleased to have had you with us today. I'm sure we'll be asking you to come back and speak to us in the future, and as we move forward. Thank you very much.
Thank you. Bye.
Bye-bye. Okay, next slide, please. Okay, so it's my pleasure to introduce Surgeon Lieutenant Commander Ruth Guest. who's going to talk to us about replacing barriers with bridges in perinatal mental healthcare within the armed forces. Ruth, are you there? Oh, there's silence. Ruth, are you on mute?
Yes, I was. Sorry. Can you hear me now?
I will switch off and let you take over.
Lovely. Thank you for having me. I'm Surgeon Lieutenant Commander Ruth Guest. I'm in the Royal Navy, and I've got a project to present to you today. It's been rehashed a few times for different audiences, so hopefully it covers the areas that you may find interesting. Next slide, please. So firstly, I thought I'd talk about who I am and how this came about, and I perhaps don't think I need to stress the importance of perinatal mental health care to this particular audience. So I am a GP. I've recently finished GP training, and I've taken up my new role as a GP in the Portsmouth base at Nelson. And this is a project that has been ongoing for the last probably 4 years, since I came back from the birth of my second child into GP training within our mental health setting, so our community mental health setting that we have within the armed forces. And when I was working there, I saw a lot of pregnant women. So we wear a different uniform when we're pregnant, and so it's quite easy to spot people who are pregnant. And I was quite shocked at how many ladies I was seeing within the community mental health setting. And it occurred to me that if they were struggling with their mental health already, that postnatally they would be at higher risk of having it come across issues with their mental health. And I wanted to look into a bit more what they knew about their access to mental health care when they were on maternity leave, and their experiences. Next slide, please. So within the military setting, healthcare can be transferred to an NHS GP, particularly in the Navy. Many of our ladies move to other areas. A lot of them work in their base ports during the week and go home at the weekends. And so when they go on maternity leave, they may be in any area in the country. Quite a few stay near base ports, but they may choose to have their medical care transferred to an NHS GP. They should have a leaving medical or a maternity leave medical, and this is twofold really. One is for us to reiterate what they're entitled to and where they can find help whilst they're on maternity leave, but also because our ladies are on mat leave can choose not to return to these services, and it means that they don't then need to come back to have a leaving medical. They should also have a return to work medical. So after maternity leave, we should be seeing our ladies, catching up on everything that's happened in the last year, sometimes more, finding out about their delivery and making sure that they're adequately protected before they go back into military duties, as they may have both physical and mental health care issues remaining. The issue is that these two healthcare systems, so the Defence and the NHS, don't routinely share information, and this could contribute to a delay in recognition of symptoms and timely management. And so from that came a project, and my aims from that project was to observe the knowledge and experience of mental health care options during maternity leave, anonymously survey using an online platform, look at those results and suggest improvements in the care provided to service women. I also don't feel that I'm particularly good at research. I'm not very research minded, or I didn't think I was at the time. So I thought I could just survey a few ladies, come up with, highlight that there is an issue and suggest areas for further, more specific research in a more structured manner. I was expecting to get sort of 10 or so responses back. I had to close the survey when I got 250 responses, which very much highlighted the issues with a not particularly well designed survey to withstand the volume of responses that I got. But I was able to summarise what was found and come to some recommendations on the basis of that. So of the 250-ish ladies that responded, 68% reported that they'd had some concerns over their mental health during the perinatal period, so the pregnancy and the year after childbirth. And half didn't know that they could access our own military mental health services via GP's referral from the NHS. 2/3 had one or more risk factors for developing perinatal mental health issues, such as significant life events, trauma, either associated with birth or not, previous mental health problems, and 1 in 5 had 2 or more risk factors. And I included a link to the Edinburgh Postnatal Depression score and invited them to look at it and consider whether they felt using that tool that they had in fact suffered with low mood or mental health difficulties. Over half felt that they had suffered with low mood. I was very particular not to create a diagnosis out of it, but it was their own perception. And of those, 71% had symptoms persisting on their return to work, and 80% felt that there had been an impact on relationships with their family. So DCMH is Department of Community Mental Health, and EPDS is the Edinburgh Postnatal Depression score. So I've just noticed someone was asking about the acronyms. Please pop on there if there's any others. RTW is return to work. The most rich source of information came from the free text comments, and normally that just gets left as blank in a lot of surveys, but actually these ladies had a lot to say, and I grouped their words into common themes. Those were isolation, military implications, information flow, perceived knowledge of healthcare professionals, and I made sure that this was perceived. I wasn't making any assumptions about the knowledge of our healthcare professionals or those in the NHS, but I feel that if a patient thinks that we don't know enough about the subject, then there's an issue there. It's a communication issue. Stigma and return to work. So when we move on to isolation, the words that came out were isolation, alone, deserted, lack of contact, loneliness, out on a limb, lonely, in limbo, adrift, unsupported. And I think that's all of those ones. It's a real issue with feeling completely part of the military and then suddenly being out in the NHS, not knowing where to predict.
Ruth, sorry to interrupt. It's just Liz. Can we ask you to speak up a little bit? A couple of people are finding it difficult to hear you. Would that be okay?
I'll talk louder. Sorry. I think it's my base unit. I hear you through my base unit. I can't get the headphones to work.
Oh, right. No problem. Thank you.
No problem. So next slide, please. Inflammation flow was another area, and the words that we used were dropping off a radar, dropped follow-up, missed symptoms. There's concerns about lack of awareness of available services on maternity leave, lack of referral despite request or perceived symptoms, and difficulty registering with an NHS GP or refusal to access civilian mental health services as not funded. So some people were turned away because they were military, didn't have the right postcode, but under the Armed Forces Covenant, this should not be a problem. Military personnel should be entitled to the equivalent of non-serving personnel. And poor communication between the NHS and military. Move on, please. Suggest more input from Department of Community Mental Health into mums groups. If this was in place, I probably would not have just ignored my symptoms. Geographically, access to Department of Community Mental Health is difficult. If not in a baseport area, consider telephone consultations. And next. Okay. People talked about not being taken seriously, felt they weren't listened to, or professionals were uninterested. They felt the return to work medical was inadequate. Military doctors showed a lack of understanding surrounding mental health. All people asked for help and didn't receive it. Sometimes people felt that an NHS GP that they temporarily registered with didn't know them, didn't know what they did, didn't know where they'd come from, and they didn't really want to open up as feeling like a bad mother to someone they'd just met. They also considered that might be a lack of expertise or capacity at our own mental health services. A few people went private. So opening up to a GP about my feelings towards my son. I didn't feel like I loved my son and I asked for help. Well, we shall look at getting him adopted then if you don't want him. Didn't know what an Edinburgh scale was. And my back to work medical consisted of a locum briefly examining me and asking if on my word as an officer I was fit to be P2, so that means signed off back to work. As I'm sure you're all aware, stigma was a huge issue. So lots of people talked about difficulty seeking help and disclosing symptoms. I haven't had the courage, I kept it a secret, wish I'd discussed it, thought I should hide it and carry on, concealed, difficult to ask for help and embarrassed. So as a result of the survey, I made some recommendations. I suggested that we needed to work on education, communication and information flow and access to services. And this education was of the service women themselves, so they knew what was available, but also to both the NHS and the military medical professionals. I felt we needed to work on the information that moved between the Defence Medical Services and the NHS, and we needed to highlight access to services and improve the way that we could get there. And this is where Rebalance came in. This was the name of the project. So it was a pilot project across 2 areas for a year, and it involved a leaflet. The leaflet started with education, and it talked to people about signs and symptoms, what to look out for, why it was important. It highlighted the Armed Forces Covenant so that servicewomen knew what they were entitled to, but it also had a message inside to healthcare professionals in the NHS along the lines of thank you for caring for this military servicewoman. These are areas that you may not realise that they have access to services such as specific physio. We've got a women's health physio and the mental health services, and a gentle reminder about the Armed Forces Covenant. And then there's a small bit at the back with a gap for the servicewomen themselves to fill out information that they think, with the guidance of their doctor, that NHS healthcare professionals should know. For example, past medical history of mental health difficulties, struggling with hip problems during pregnancy, all things that these NHS doctors won't have access to. Next slide, please. And the last thing was a trial of a self-referral into our mental health services, so not needing to go through a military doctor or NHS GP. Looking at the results, these servicewomen who had the Rebalance leaflet were more aware of warning signs, knew where to seek help, were aware of their entitlement to NHS care, and it was well received by patients and clinicians. So how we got to where we are now, the project has been rolled out tri-service, so the RN, Army and RAF all have access to self-referral for women who are pregnant and postnatal into our own mental health services. There's a specific number that they can call and they're assessed, and then they are sent to their referred to their local Department of Community Mental Health. Now, issues with access is actually easier at the moment because we're doing a lot of video consultations, but they also, if they couldn't get to those services, would be entitled to NHS care also. The leaflet has been rolled out throughout the Navy, and a similar sister document has been used in the Army. Next slide, please. We've also launched this infographic, which I've tried to share as widely as possible, and this is aimed at our NHS colleagues, just highlighting in a snapshot the sort of access to healthcare that these servicewomen can get. And so it's not just about mental health care, it's dental treatment, physiotherapy as well, and some contacts. And I can share that widely should anyone wish it. And I think that might be my last slide. Yes. So I hope you managed to hear most of it.
Thank you, Ruth. Again, really insightful, showing us into the kind of the window of the armed forces. Really useful talk. Has anybody got any questions or comments for Ruth?
Hi Ruth, it's Jenny here. I've got a question about, so I think there's quite a wide geography on this call, so services that will have a number of different armed forces on their patch, and Is there, what would be the best way to sort of reach into those services? Is there a particular contact or a particular area? Because it's a bit of an unknown quantity, I think, how the armed forces is set up. It's a bit of a closed shop sometimes if you're on the outside. And I just wondered if services wanted to make sure that they were being accessible to these women. Is what's a good in for people?
That's a really good question. Certainly from the Navy point of view, we have maternity cells. So in the main baseball areas, Scotland, Plymouth and here in Portsmouth, we've got maternity cells where there is here we've got a warrant officer who is kind of like a mother hen to all pregnant people. She sorts all of their issues regarding work reporting, but also any welfare issues. She's a really good point of contact. She spreads information out. In the army, it's more centralised, and if I'm trying to think really the best way in, it would be about finding out who's local. Is there a local base? And their medical centre would be more than happy to liaise.
Okay.
It's a tricky one. The RAF, I've got less experience with, but I think it's once you've found one patient, tracking that back to where they've come from and hoping you can spread the word that way.
Yeah. Thank you. That's really helpful. Thank you.
Any other questions for Ruth? Lots of really positive comments again in the chat box. Very informative, very thought-provoking. Charlie, I think you've got your hand up.
Hi Ruth. So you mentioned in your talk that the NHS doesn't have access to the military healthcare records. Is that something that can they be sent like a GP record would be, or are they confidential?
That's a really good question. The problem with our records is they include a lot of information that isn't relevant outside of the armed forces. So when someone leaves, we actually only do a summary printout and don't give all of the information. It's available on request. And that's the same issue with on maternity. But I've encouraged when they use the booklet, they both write key information that belongs to the patient and they can choose. And it's an education point as well, that making the patient aware that these things may put them at risk and what to look out for. But we can also at that time do a summary printout and attach it to the booklet. But that's up to the patient, as it's a bit like a handheld record. There's no real way of doing it universally.
So I'm thinking about our self-referral forms in SHIP. So Portsmouth is part of our LMS patch. Would it be an appropriate question in those self-referral booking forms to say something along the lines of, are you serving military personnel? Do you have a rebalance booklet as a prompt from our end?
That would be absolutely fantastic, and I think that would be a really good thing. Certainly when people move across as permanent residents to the NHS, when they leave, they are invited to say whether they're a veteran or not. Because of the slight differences in services. So I think it'd be completely appropriate to ask in areas of high levels of military personnel, are you a member of the armed forces? And have you heard of this booklet, particularly in the Navy? That would be brilliant.
Fab. Thank you ever so much.
Thank you.
Sorry, I'm talking whilst I'm on mute. Okay, thank you very much, Ruth. And as I said, lots of really positive feedback in the chat box. Thank you for taking time out of your schedule to join us today. Next slide, please. Okay, I'm now going to welcome Caroline Dan, who's going to talk to us about supporting gypsies and travellers in Cornwall and the South West. Over to you, Caroline.
Hi, everybody. Can you hear me okay? Do I need to put headphones in? Is it sounding okay?
Sounding good and clear to me. Everybody else?
Brilliant. That's good. Okay. Well, my name's Caroline Dan. I'm Managing Director of the Traveller Space charity. I've personally been working with travellers since the early 90s, and we formed the charity in 2002. A lot of what we do is about breaking down barriers to improve access to health, education and welfare services, and we always look for partners in those services in order to better deliver what we do. Next slide, please. So I'm going to give you a little bit of background of what we do and a little bit about the Gypsy and Traveller community. I apologise if you already know this stuff, but I'm going to rattle through it a bit because I think it's a good background to the actual delivery of the work, and then I can talk a little bit about a flagship project that we were involved in with local midwives. So this is our play bus, which we take out to families who are living by the side of the road. It's obviously aimed at children. We can get up to 14 kids on the bus and a couple of project workers, but it's also a tool in order to get out into the traveller community, and anyone can come and see us and get access to any of those services I mentioned, and we can signpost them to those services. We can read letters for people. We can do all those kind of things. Next slide, please. Next slide. Thanks. So yeah, back one. Thank you. So yeah, this is us doing a roadside visit to some horse-drawn travellers, just to give you an example of that. Okay, next slide. We also took over the running of a children's centre a couple of years ago as a charity, and the centre now is almost exclusively used by the traveller community who live nearby. This is our Gypsy and Traveller Women's Group, which we've been running since 2005. We get 35 to 40 people turning up every week, and as you can see from the slide, we get young babies, young children, older kids, teenagers, young women, older women, everybody. It's a great opportunity for other service providers to come in and talk to people in an informal session and talk about what their services they provide. And we have regular visits every week from the health visitor, midwives and other support workers, and also staff from the local school and so forth. So it's a really good way of getting an introduction into the community. Okay, next slide. Right, a bit about numbers, give you a bit of background. So nationally, Romany Gypsies are the biggest group, or were the biggest group. I'd like to say around 200,000 Romany Gypsies at any one time. I'll just point out at this point that the picture that we have of Gypsy and Traveller people is that they're all in caravans or vehicles or so forth. 75% of the community are housed. Romany Gypsies originate from India and have their own specific language and culture, and are entirely different to the next bit, which is, does that come on as well? Yeah, Irish travellers, who obviously originate from Ireland, who tend to be smaller in number, and the people that we see down in Cornwall are mostly very highly mobile. We only see them for a few weeks and then they're off again. So it's quite difficult to get services in with the more mobile communities. New travellers are basically travellers who originate from the settled community and make a choice rather than that being their ethnicity. So the top two groups, that's their ethnic status. New travellers are people who originate from the settled community, even though most of the children we see may be second or third generation new travellers. That number is growing because it is an easy and cheap option if you cannot afford your rent or you've lost your job, which indeed a lot of people are doing at the moment. So that number is always going up. And then lastly, European Roma, who have the same ethnic root as Romany Gypsies, originate from India, but have very, very little to do with each other and aren't nomadic. Okay, next slide. I am rattling through this, so if you've got extra questions, you can always contact me separately. This is a council-run site, and we've got 3 in Cornwall. You may have 1 or 2 in your own area, or you may have none. Families who get a pitch on the council site, they pay rent, rates, gas, electric, the same as everybody else. It may be that people you are wanting to see live on one of these sites. I would suggest that the first time you go with a trusted support worker who knows all the families, and that may be someone like us. Partners are always good. Trusted partners are always really handy. So it may be someone from a charity like us, or there may be a support worker who works for the council or somebody like that. So find that out first. That person will introduce you to all the families and the people that you need to know, and will also kind of acquaint you with some of the visiting protocols, which I haven't really got time to go into, but that's basically what I would suggest initially, and then you should be absolutely fine to go on your own. There's no reason why health professionals shouldn't visit the site. Okay, next slide. And just to give you a little bit more understanding, this is a sort of standard pitch. You've got the tour, and then the building at the side there is the day room, which is divided into a kitchen and bathroom. And culturally, Romani gypsies do not cook indoors or use the wash or use the toilet in the trailer. They will always use the day room, or they will cook outside. Okay, next slide. As a complete opposite, this is what we'd call an unauthorised site because it's in a lay-by or a chippings yard. These kind of vehicles are used by, typify the new traveller community. They tend to buy old vehicles and do them up, put a chimney in them and so forth. So you're looking at a different set of problems if you're visiting a site like this. The usual problems are lack of running water, lack of sanitation, lack of electricity, all those kind of things, and vigilante attacks, because quite often those people are very isolated. So it can be quite a dangerous place to live. What you don't tend to get are the problems with literacy. Largely, I'm generalising, but I will come on to that because literacy problems are a big issue. Okay, next slide. And just to make that point again, that 75% of the community are housed or live in chalets, and that it may be that they don't want to be, but they have settled in order to access health, education, or welfare services or permanent work. So there may be reasons for that, but the cultural issues are still there. Okay, next slide. So this is what we come across and we are dealing with as a charity. A lot of the time is the level of discrimination and racism suffered by the community, which very often starts, with very young children. And I think it's useful to have that kind of background to what you're doing to understand where a lot of the distrust of the settled community comes from. Next slide. So some of the work that I do is going into schools, and I talk to quite often Year 9 children to explain to them about stereotype and discrimination and so forth. What I do is give out a post-it note to all the kids and ask them to write something that they know about the Gypsy and Traveller community on their post-it note. This is a pretty standard selection of what I get back, and these are Year 9 children. So they have learnt that from the media, and they have learnt that from their parents. So the people that you are potentially working with have all that going on in the background, and that you may think those things about them. Okay, next slide. So again, racist bullying is one of the major issues that people from the Gypsy and Traveller community drop out of school. And 9 out of 10, if you just go down one more click, 9 out of 10 travellers have experienced racist bullying and violence in school. There's another bit to that slide. Yeah. Have suffered racial abuse, bullying, or have been physically attacked in school. So many drop out of school. And then next slide, we have very low levels of educational attainment, and that becomes this is very often racism is very often unchallenged by teachers, because they don't understand that words like pikey are racist terms, and these things tend to go kind of unchallenged, basically. So we're dealing with, particularly in the Gypsy Traveller community, very low levels of literacy, which becomes a major issue when accessing services. Okay, next slide. So some health outcomes. Because of poor access to healthcare and general living conditions, it's estimated that Gypsy and Traveller women live 12 years less than women in the general population. That's thought to be an underestimate, and it's more like 25 years actually. Coupled with that, we have high infant mortality rates and high maternal mortality rates, and a prevalence of mental health issues and anxiety, which is higher than in the wider community. Okay, next slide. There's some research done by Save the Children that says that, you know, most services have an open door policy, and I've heard many service providers say to me that if gypsies and travellers aren't accessing their service, the assumption is that they don't want it or they don't need it, but actually they don't know about it. So there's an assumption that if you have leaflets, that people will be able to read them or access them, or you can go to the website. Most of the people I work with don't have a phone, don't have any internet access, and can't read anyway, and certainly can't navigate around a website. Those are the high need families that I work with. Obviously there's a broad range of people who are perfectly capable of doing that, but I'm talking about the families I see with the highest needs. Okay, next slide. Registration is an issue for a lot of gypsy and traveller people, having trouble registering with the doctor, and that's still a thing, I'm afraid, because if they're living roadside or they're nomadic, they don't have a permanent address. There's another bit to that slide. And it's often a flashpoint for difficulties. Some GP practices are unwilling to register people if they can't prove their address. Next slide. And obviously it's fine to ask for an address, but surgeries should have procedures to register and offer services to patients who can't prove their address. Okay? So the guidance is clear, you don't need that. You will also find that there are cultural differences that may not be initially apparent. So there are several distinct cultural groups within the umbrella term gypsies and travellers with widely different traditions and practices. The main one that you need to know about is that for gypsy women in particular, they may not share or discuss health issues with male members of their family. Okay, next slide. Women are the main carers of children, and women and in the family generally, not just the mums, and may have to bring other children to appointments. That includes siblings needing to bring younger children with them and so forth. They may have no access to transport during the day if the men are out with the vehicles, and they may have to make do with evening appointments and generally have to take children with them. And they may only agree to see a female doctor, so be aware of that. Next slide. So with all that in the background, I guess it's important to understand that people may be wary of professionals from the wider community, and there's a perception that they may take their children away. And it's important to be welcoming and patient and understanding, even if people turn up with a lot of kids to their appointment and it's noisy and a bit chaotic. That's kind of goes with the territory, really. Okay, next slide. So having a look at your services, when you're looking at very, very low levels of literacy, and I think often people's perception of low literacy is not being able to perhaps read a letter very well. A lot of the people I work with can't write their own name or address, and what goes with that is also can't tell the time. So appointments are really problematic for people who can't read the appointments or the reminders or tell the time, and they might not tell you that. So just be aware of how your information is out there. We tend to always communicate face to face, or by phone or by voice message, rather than text if we need to contact somebody, particularly in these kind of COVID times. Okay, next slide. Right, so this is the project that I wanted to talk to you about the most, and I'd like to start by saying we've worked with really great midwives over the many years I've been doing this job, but we had a midwife who worked with one of our nearest sites for many years, and when she was when she knew everybody and everyone loved her. When she retired, someone else took her place, who unfortunately immediately decided that the site wasn't a safe place to be, and was demanding that women met her in a lay-by so she could talk to them in a car, in the back of a car. We complained about this a lot to everyone until I found someone who would listen, and the project Maternity Voices got involved with us and realised that there was a real problem here, in that the women we work with have the poorest maternal and neonatal outcomes of any other BME group, don't tend to engage easily with healthcare professionals, and high levels of smoking, diabetes, very, very low levels of breastfeeding, and multiple and complex other needs. So we had the Maternity Voices project, and they came along to our women's group and to talk to the pregnant women about what kind of services they did want and what the issues were with accessing those services. They realised quickly that their surveys weren't going to work because people wouldn't fill them out or couldn't fill them out. Feedback forms, none of that. So they did a lot of listening and scribing for people. It's never in an ideal sessions. You saw the picture of the first picture I showed of the women's group. It's always noisy. There's always a lot of kids running around. But they worked with the women over a number of weeks and formed a really good partnership between us, the women from the site, and themselves. And then realised that various things like words like maternity, even for women who've had several children, they didn't know what that meant. And so you have to be really careful about how you express yourself and make sure that people really do understand what you're saying. So out of this work with Maternity Voices, these two midwives here that you can see were employed to work on a part-time basis with the pregnant women from the site that we were working for. So they came in and they visited the site, visited everybody, got to know everybody, and they also co-designed a logo for their service. So they're called the Tuluva Midwives because our centre is called the Tuluva Centre. And you can't really see it very well, but the logo on their uniform is a horseshoe with a pregnant woman with a heart in her belly. So they did all that together. They worked out themselves that they needed to see people in the same time in the same place every week. So they actually come to our women's group every Wednesday and operate out of the back room, seeing people, so everyone knows they will be there and that they can talk to them. They also made sure that there was a named health visitor, consultant, GP, and themselves that people could refer to, so they all saw the same people all the time. They also realised quickly that asking people to come at 2:20 and things was just never going to work. So always o'clock appointments, always draw clock faces on the card to show what the clock looks like, analogue and digital, to tell you when your appointment is. And those important partnerships with services like us and the site support worker, it was important to follow up every appointment, phone up on the day to remind people that that's the day of the appointment. A lot of people I work with don't know the days of the week either. And also then half an hour before to remind again that it's time for the appointment. So it's very work heavy, if you like. But if you have those good partnerships that you can form with people who can help you with that, it makes it a whole load easier, basically. So this has been a really successful project, and the women involved were delighted with it. They were delighted to be involved and felt they'd been listened to properly and that their concerns were properly listened to. Okay, next slide. So on the back of that, remember that to ask people about form filling. It doesn't, some people won't tell you that they can't read or write, so I'm quite happy to do so. But I always kind of, if there's a letter that someone, I always say, so this is about, generally explain what it's about. Do you want a hand filling it in? Is a perfectly acceptable way, I think, to talk to people who may not be able to read and write very well. So just remember that with all the paperwork that comes with things, that it may need explaining to people. And also, please don't assume that people go on the website. The nearest site to us has no internet access at all, and very little, the people who live there tend to have very little knowledge of how to use the internet anyway, or how to access a website. And the last thing on that, don't assume letters will arrive, just the last slide there. Don't assume letters will arrive. Quite often the postman will turn up and give all the letters for the site to one child, who may throw them in the hedge, who may sort of indiscriminately give them out. And if they do arrive, they might not, people might not be able to read them. So face-to-face communication is always best. Okay, that's me. Does anyone have any questions?
Thank you so much. Any questions? Oh, sorry, there's a bit of feedback. So positive feedback in the chat box. Any questions for Caroline before we finish her session? Ellie, you've got your hand up, and Charlie after Ellie.
Hi, I'm Ellie Fenton. I'm from Dorset LMS. I was just wondering of the best way to get into these groups. You're talking about the MVP reps going to the women's groups. How do we know if these women's groups are happening in our area?
Yeah, the women's group we set up in response to requests for women from the site who wanted somewhere to meet away from the site and to get help with stuff we do, cooking and all sorts of stuff. So that happens in Cornwall. It doesn't necessarily happen elsewhere in the area that you live in. But if the women you're working with are living on a council-run site, they may well have support workers.
I think I've heard of a Gypsy and Traveller Liaison Officer at our council. So I'll get in contact with her.
They're good people to contact because they very often know all the families.
Okay.
And so they're a good person to go round with and meet everybody. So you may not have the luxury of coming to a women's group like ours, but you may at least be able to go with somebody who can introduce you to everyone, and then you know where everyone's trailers are. You've got the geography of the site.
Yeah.
And it just makes life a bit easier. Also, if people see you with someone they trust, then that's a really good first.
Yeah, it really
step.
helps. Yeah, it was really interesting your comment about the surveys, because we try to do lots of surveys, but of course it's just not relevant here, is it?
No,
they're not going to fill them in. So it'd be really good if we can get our MPPs out to the sites, I think, if they want to do that. That's great, thank you.
Okay,
thank you. Charlie.
Hiya, thank you for your presentation. It was really interesting, and definitely something that I haven't thought about is you mentioned Gypsy and Traveller groups in the context of BME communities, and that's certainly not a link that I've made. I don't know about our services. I wouldn't want to speak on their behalf, but obviously we've been focusing very much on those Black and Asian and Indian communities. Yeah. And I was just wondering if we are expanding our ethnicity criteria for disclosure and for monitoring and making sure we provide the right services, what should we be putting there so that we can specifically grab the communities that do fit into that BME group? Because I appreciate the new travellers maybe not so much.
No, they're not part of the. They're not an ethnic group. But we work with them regardless. The ethnic groups would be Irish travellers and Romani gypsies. So if you're doing some sort of monitoring form, you can put gypsy or traveller on as a tick box, as it were. We tend to go with how people describe themselves. So we go with whatever term they use. Some gypsies prefer the term traveller. Irish travellers tend to use the term traveller. New travellers sometimes use the term traveller. So it is confusing until you get to know people better. But if you put gypsy or traveller, then that really kind of covers everyone. That's not going to cause offence.
Fab. And can I sort of extend that question as well to Liz, actually, or anyone who is on from NHSE? When we're looking at sort of the regional and national comms around BAME, is that something that's being considered as an inclusion criteria in those BAME groups?
I think that's a really good question, Charlie, because I don't think it necessarily, I hope I'm not speaking, but my interpretation is I don't think it always has been included. So I think it's something for us to take back and for wider discussion. I don't know if anybody else wants to comment.
Well, I think Jenny Hughes has popped her hand up, actually, which will be from the horse's mouth, I think.
Well,
I'll hand over to you.
Thank you.
We've just been discussing this with the rest of the regional chief midwives and have gone back to Victoria Morgan and the national team to come up with a proper definition so that we know what we're working with. So watch that space, because Victoria's on holiday this week and we're hoping when she comes back that will be fully clarified.
Thank you, Jenny. That's really helpful. Okay. Thank you so much to all our speakers today. I know that you've all got busy schedules, and I think today has been a really thought-provoking and informative morning, and I think we're very lucky to have had you all come to speak to us today, so thank you. Just in terms of wrapping up before we launch onto the film, as you're aware, we will share the slides after the webinar. The recordings will also be available. And as always, if you were forwarded this invite, please let us know so we can add you to the distribution list. Next slide, please. Just in terms of forthcoming webinars. So our next full webinar is Wednesday the 30th of September, when we'll be focusing on IAT and system-wide working in perinatal mental health. But there is also a webinar next week, as I mentioned earlier, which is in response to the maternal mental health services, which is focusing with public health on the inequalities resources to support the bids. So the invite has gone out to a more targeted group for the maternal mental health services bids. But if you wish to join and you haven't received an invite, please let us know, because it is although we've targeted it, it is open to anybody who wants to attend.